Next case is a large secondum ASD with severe PH. This is a 21-year-old female with progressive dyspnea on exertion since last 5 years. She weighs around 37 kg with saturation of 100% on room air. On examination, she has cardiomegaly with left parasternal heave. There is a S1 is normal, wide and fixed split S2 with loud P2. There is a short grade 2/6 ejection systolic murmur in the left upper sternal border. This is a chest X-ray which shows a cardiomegaly with CTR of around 60%. There are dilated MP and central PAs. This is the ECG showing a sinus rhythm with PR interval of 160 milliseconds, a right axis deviation with around 105, and a RVH with strain pattern which is seen in specifically V1 and V2 leads. This is a TE image with horizontal plane done in 0 degrees, where you can see the large secondum ASD which is present, which on 0 degrees measures around 24 millimeter. This is a bicaval view of the same, where the ASD measures maximum of around 31.5 millimeters. Patient had severe PH with the RVSP around 88 plus RA with mild TR. This is a 3D image. There was a deficient retroaortic margin with all other margins being adequate. Around 1 month back, she had underwent a cardiac catheterization where we demonstrated that basally the mixed venous, there was a step of around 21% from mixed venous of 63% to 84 in the PA. There was no step down basal. She was the basal hemodynamics had showed up moderate to severe PH where PA pressures were 98/40 against aortic pressures of 120/72. She underwent a vasoreactivity testing with nitric oxide and oxygen, where there was no reduction in the PA pressures, but however the QP/QS from basal of 2.62 increased to 4.94. The basal PVRI was recorded to be 8.8 Wood units meter square, which was around on nitric oxide, which reduced a significant reduction to 2.4. And PVR to SVR from 0.26 to 0.13. The plan is to repeat the cardiac catheterization, do a balloon interrogation of secondum ASD to assess the hemodynamics, that if there is any further fall in the PA pressures, and then proceed with the device closure of ASD, as to plan on table whether a usual device would be okay or that we would have to choose a fenestrated device based upon the hemodynamics of the patient.
So,
Eric, would you like to comment on this case?
Yes, Steve, I just wanted to ask, you don't use 100% oxygen to test, and when you use nitric, is it in room air as well?
no, nitric oxide with around 5 to 6 liters of oxygen. Actually, I'll tell you, Eric, the problem that we have. When I give nitric oxide through the tight-fitting mask, the nitric oxide replaces the oxygen in the room air, and that results in marked reduction in the FiO2s. And so we have made it to run parallelly two tubes. One will run about 5 to 6 liters of oxygen, and the second one will run nitric oxide to reach 40 to 45 parts per million, and this combination will be driven. We tried initially only nitric oxide, and this is on spontaneous breathing. This is not on a ventilator circuit. On a spontaneous breathing with a tight fitting mask. I need the needle ready. What happened was the FiO2s go low. So when we check the pulmonary vein PO2s on a patient who is on full nitric oxide, the PO2s will be 60 to 70. So we decided always to give a combination of oxygen plus nitric oxide.
How but do you don't just do 100% oxygen testing?
Not 100%, it is not 100. See, basically...
but you do 100% oxygen without nitric.
We don't check it nowadays at all. We always put nitric oxide. We don't check the pure oxygen testing that we used to do like maybe a decade ago. We have stopped it. Now we are totally going only for nitric oxide oxygen combination.
Well, we usually use 100% oxygen and nitric. Interested in the audience, does anyone just use 100% oxygen alone, or does everyone use it with Masood?
We don't have nitric oxide, so we have no choice, but we use 100% oxygen. What is surprising here, Shiva, if you can hear me, it's Masood Sadiq here. If you look at your pressures, your diastolic pressure hasn't come down, your mean pressure hasn't come down. but your QPQS and your measurements, whatever it means, it shows that your PVR has dropped. It's really hard to believe because if your pulmonary artery pressures were not dropping at all, including mean and diastolic pressures, it's hard to believe that you actually had a reversibility or reactivity.
Okay. Now,
So you, Masuk,
actually,
you
can
see, you
can you
are
go back to the
concerned
PowerPoint?
about this data.
Sorry?
So what would you do?
I would have tried occluding at the same time when we gave nitric oxide and see if balloon occlusion will drop the pulmonary artery pressure at all. Because PVR alone, I wouldn't close this AST unless the pulmonary artery pressure drops. If the pulmonary artery pressure does not drop, then I would not close the AST.
Have you
At all,
further
would you
comment?
not close it at all?
Is the
Or
patient,
since
sort
we
of,
think she has
well-
some reactivity, would we then institute a pH regimen and then potentially retest?
Yes, yes. I agree with that. You will put them on pulmonary vasodilators for a certain period of time, then come back and do a hemodynamic assessment again
the
and
center-
see whether that would actually, you see some element of reactivity, particularly a drop in, we find a drop in diastolic pressure, a very sensitive index of pulmonary vasoreactivity.
Okay.
And
So-
what about to put a fenestrated device right away and treat the patient with drugs against the pulmonary hypertension?
You could take it either way. You could either, I would prefer giving pulmonary vasodilators first, and then if there is some degree of
Another
vasoreactivity,
catheter?
still I would put in
Yeah,
a
pigtail catheter?
fenestrated device and not completely close it.
Okay. Show the PowerPoint. Show the PowerPoint. The pressure trace page again. Once again. Yeah. You observe there, Dr. Masood, that the moment we start giving nitric oxide with oxygen combination, the pulmonary artery PO2 shoots up to 95. This significantly causes the thick oximetry based calculations to go, open both the pressure lines, to significantly go, like the QP is enormously increased. I do agree that the pulmonary artery diastolic pressure is not falling at all. And so that is of concern, and that was the reason why we did not close. At that point, even though the PVR has fallen down to 2.4 and the PVR by SVR ratio is almost 0.13, we decided not to close. We decided to treat her with pulmonary vasodilator, and so she has been on pulmonary vasodilator for the past few months. Now we are repeating the hemodynamics. So show the hemodynamics screen big. What you see on the yellow is aorta, and what you see on the red is pulmonary artery. Make it 100 scale both 100 scale, and increase the speed. So the pulmonary artery diastolic pressure is somewhere around 38 or so. Pulmonary artery mean pressure is about 60 or so. So what we are currently going to do will be this catheter. I'm going to advance through the ASD, and we are going to do a balloon occlusion and see what happens to the hemodynamics. Because I want a stiff wire now.
Is she on single agent treatment, or what is your regimen now?
She was on dual drugs. One was an endothelin receptor antagonist in the maximum dose, and one was a phosphodiesterase 5 inhibitor in the maximum dose. We have not started Selexipag, which is also available in our country in the recent times. And we in our country, we don't have a free access to any of the intravenous prostanoids. So what I'm going to do is study the hemodynamics on a balloon occlusion over a period of, say, 5 to 10 minutes and see what happens. The patient is conscious. She is breathing on her own.
Siva, just
there
a
is there a
practical
dilator for this?
question. Before starting to put a balloon occlusion test, what would you expect? So, what are the difference or variations that you would expect to carry on to close the defect with an ordinary device, to put a fenestrated device, or
Yeah.
give up? There are three options you are facing with.
Correct. Mario, from the previous data itself, we have information that tells us that we are okay to close this ASD with a fenestrated device. Show the PowerPoint again. See, that table is most important. That's the reason why I'm bringing it again and again. See, here we are observing that the patient is having a QP that is significantly going up. The basal QP itself is high, and the pulmonary vascular resistance is dropping down to almost 1/3 of the basal value, and the PVR by SVR ratio is significantly low. So this tells us that she is acceptable for a fenestrated device. Now today, we probably will look at what is the balloon occlusion pressures, and then take a decision. Okay, get me the Amplatzer sizing balloon. Just hold it.
And then ultimately, for your device closure, do you have intracardiac echo for guidance? Say she's nice and conscious, it would be nice not to have TE, but how do you guide it that way?
We have the age-old transthoracic echo guidance, Alison.
Oh, transthoracic. I forgot there was transthoracic.
So we, in fact, the reason why I avoided a transesophageal echo and an intubation was that to keep her fully conscious and to get the most uncorrupted hemodynamics, because any amount of sedation that I give for facilitating a transesophageal echocardiogram is going to result in alteration of the hemodynamics. So I just wanted to avoid it totally. Now I'm having 1:4 dilution of my contrast, which I'm going to inflate this sizing balloon, de-air it,
We have a question from the audience.
yes please. Hold it.
Is there anything that the balloon occlusion would show you that would stop you from closing with a fenestrated device? So are you doing it with a view to potentially not closing, or are you doing it for completeness?
Is it, may I know who is speaking?
I'm Radwa Bader from Bristol, UK.
Hi. The purpose of doing this balloon testing is to find out whether there is going to be any amount of drop in my pulmonary artery pressure. Can we get the catheter? If suppose the pulmonary artery pressure is dropping with, get me the thermo wire. If the pulmonary artery pressure is dropping significantly without a drop of the aortic pressure, I'll be very happy. I still will go ahead with a fenestrated device. But if the pressure is not falling at all, absolutely not falling, then I will be thinking about continuing medical management. Show me below. Continuing the medical management with pulmonary vasodilator. Show me below.
And not closing at that point?
And not closing and waiting for some more years and then take a decision. So I'm going to have a parallel pulmonary artery catheter.
The reason I ask is because I think that part of the pulmonary hypertension that's flow mediated doesn't reverse immediately. So I think you put the balloon up, and I don't think you immediately see the pressure drop. You may want to wait a while, and then you see a pressure drop. And I wonder whether there's an element of it that reverses gradually over, I can't tell you, but I think there is an element that may then reverse over days and weeks. I think that her hemodynamics, even before today, would have been relatively favorable for a fenestrated device, because it's the QPQS that's left to right predominantly.
I too had this sort of idea that in a post-tricuspid shunt, a closure of the shunt is going to result in an acute drop of the pulmonary artery pressure, but in a pre-tricuspid shunt, the drop will not be there. However, on the contrary, when we started balloon occluding many of our pre-tricuspid shunts, that includes sinus venosus defects as well as secondum atrial septal defects, we have observed time and again there will be a substantial drop of the pulmonary artery pressure immediately on balloon occlusion. Let me see what happens to this particular patient. I am just de-airing the system. I want a three-way. Connect the three-way into this. So now what I have done is I have put in a balloon. I have connected to pressure. So we are having a simultaneous aortic pressure as well as pulmonary artery pressure. And okay, this is inflating more in the, go inside. Yeah, thank you very much. I forgot to introduce the doctor who is now assisting me is Dr. Vishnu, who is one of my senior fourth-year fellows. So now I'm just getting my balloon, keep it forward pushed. Yeah. So now I have got my, keep a forward push. I have got my atrial septal defect occluded. My go-to big screen hemodynamics. Take away the camera, big screen hemodynamics. So right now what we observe is the pulmonary artery pressure is coming down to somewhere about 55 to 60. The pulmonary artery mean pressure is about 45. The pulmonary artery diastolic pressure is touching 30.
Yeah, so you have a very nice drop.
Some
in
amount
your
of drop.
pressure.
Now what I'm going to do, Alison, is to aspirate my balloon. Go back to pressure again. Yeah. Now I'm aspirating my balloon and I'm seeing whether the PA pressure increases. Now wait for some time. The balloon is getting deflated. Now my balloon is getting
Can we
deflated.
see your fluoro as you do that also?
Yeah,
Yes.
this is even
Okay, so it's all the way
better than
down.
expected, isn't
Yeah.
it?
So this
Yeah,
is,
that's very encouraging.
yeah.
So
now
in
I'm having pulmonary artery pressure which is 75% of systemic right now, and when I inflate, I am inflating now. Keep a forward push. I'm having an increase of the aortic. I'm having an
expect
increase
this
of the aortic
response?
pressure and the fall of the pulmonary artery pressure. This is what we have observed time and again in majority of the patients who have hyperkinetic pulmonary hypertension, or in other terms, quite a reactive vascular bed. While the nitric oxide, go back to PowerPoint, the last picture. Go back to PowerPoint. The last, yeah. If you look at the nitric oxide, on nitric oxide, the pulmonary artery pressure did not fall because the flow was continuing. The flow, perpetual flow, is preventing the PA pressure to fall even though the pulmonary arteries are very reactive. Whereas when we occlude it, we are able to demonstrate the fall. So I'm convinced pretty much that this patient will benefit from a closure, but to be on the safer side, I still will put in a fenestrated device. I'm not going to be very aggressive in trying to put in complete closure. So right now what I'm doing is...
Siva, I think those pressures look very good for complete closure, but I'm going to ask Masood whether he'll give you permission to close the defect now.
Absolutely. I think we would have done it in the first instance as well, probably, when we gave nitric oxide to see whether there is a reversibility. But after treating it, there's a clear evidence that your PA pressure is falling after the balloon occlusion. So I would have actually closed it straight away because the fall is dramatic. You can see that your diastolic pressure has come down, your systolic pressures are now 50% systemic, so it's a flow-related pulmonary hypertension.
Yeah, we would
So
not
I think
expect such a dramatic change, isn't it?
So, Eric, you alluded to this. How many in the audience would consider complete closure, perhaps ongoing treatment with pH therapy, and then at not doing a fenestrated closure? Complete closure? Show of hands? Okay, we have a handful of us who might be brave. Fenestrated closure? Similar.
51 to
49, maybe.
We could Brexit on that.
Is Dr. Dietmar Schranz in the audience? Dietmar Schranz.
Dietmar is not here that I have seen.
We'll
Dietmar
try and
will-
get him,
would-
Siva,
Dietmar
to
would
try and get
love
the
me.
casting vote.
Dietmar would love me if I say that I'm going to put a fenestrated device.
what kind of fenestrated device you're going to put in? I mean, an ordinary device, you put a small hole, a couple of holes. What's your precise policy to fenestrated an ordinary device?
What do you do for Mario? What do you
Well,
do?
I'm very simple, man. I just put a needle inside and do a balloon, or maybe a couple of small balloons in order to have 2 little holes that are likely to get closed spontaneously with time.
How many in the audience have got the luxury of using a dedicated fenestrated device that has been made to stay permanently open till you decide to close it?
Show of hands. There's maybe a half dozen people in the audience that have a pre-made fenestrated device.
I do have
so
that.
the rest
I do
of us
have
may
that
have to
luxury.
create it.
I want a 34 fenestrated AST device. I want to show the device first.
Yes, please show us your device.
Is it 34 or 30? What was the size that we got? No, our transesophageal was 30.
Did you measure the indentation of the size in balloon when you implanted it?
Actually, we have done a transesophageal echocardiogram and we got 30 millimeter Mario. It has been
Yeah,
our.
there was indeed an indentation
Can you
of
show
the
that?
balloon.
Can you show that balloon inflation?
Yeah, I think
Now,
you showed us
open
it
the device.
was
Open the device.
26 by 31, 32 by
Somebody can
T.
measure this waist. This is a 15 millimeter. Can somebody measure? I will try to get it while I am showing you the device. Somebody will make a measurement. So this is a dedicated, custom-made fenestrated device. I will show you the device. So this device has got a 8 millimeter fenestration, custom-made. It will stay open till the time I want this hole to be closed.
How big is the fenestration?
8 millimeter.
8.
8. The nitinol wires have been bent at that area. The fabric has been closed in such a way that it will stay open ever. Now I want the short loader sheath and I want the LifeTech loading cable. Somebody measure it, please. LifeTech loading cable.
What is manufacturer again? I'm sorry.
This is made by the LifeTech. LifeTech
Thank you.
is a company from Shenzhen, China. And I think LifeTech devices are widely available in Europe. Is it not, Mario?
Yes.
Yeah, but probably the fenestrated devices are not distributed there, right?
Yeah.
We use a lot of this in both restrictive LV physiology as well as, I want more saline into it. We use this a lot in restrictive LV physiology as well as in pulmonary hypertension on the treat and close strategy. So as I show you, that is the fenestration. It's showing up nice on the camera. I'm able to see that.
So the other device we have in Europe is the Occlutech, which will also give you a purpose-built fenestrated device.
Correct. We have used both these devices quite often. And actually, I think one of my colleagues, Dr. Pramod Sagar, is making an analysis of the long-term patency of fenestration in these patients. I think we are touching somewhere close to about 25 to 26 devices. And Pramod is making an assessment of the fenestrated device patients, what is their outcome, and also okay. Now fluoro store this and repeat this. Now while Srija will show echocardiography. Is anybody made a measurement of this waist now?
You didn't monitor the device released by echo. You just see afterwards, right?
Yeah, based on fluoroscopy, Mario. Once upon a time, we used to do only based on fluoroscopy, no? So now Srija is now getting the echocardiogram. Make the echo bigger. It's a
Wow, looks a bit bulky, isn't it?
Yeah,
Close
it's
to the mitral valve, isn't it?
yeah. We will try to show you all the valve and its relationship. Come here. Eye up. Eye up. Now show that this balloon waist. Yeah, make the balloon waist bigger. The fluoroscopy bigger. Fluoroscopy bigger. Yeah. So it was measuring around 30.
So now we can see good device position, and
Yeah,
your
now-
pulmonary pressure is not quite as low when the balloon occlusion was carried out, right?
Yeah, because this is partial occlusion, and also the
Right, you
fabric.
still have flow.
The fabric still will have flow, and moreover, see now zoom on the mitral valve, Srija. One by one zoom on structures. Make the mitral valve alone. Yeah. Show the mitral annulus. Yeah.
How many options of custom-made devices have you got there right now?
We have got sizes starting from 26 to 46. 26 millimeters to 46 millimeters. Can you check the
Hey.
TR gradient?
Yeah.
There was
Go
a moderate tricuspid regurgitation before because of the pulmonary hypertension. We are just remeasuring the pulmonary artery pressures.
We had a high. We had a child who was 5-6 years old who we put a fenestrated device like this, 27 millimeter, because it was very large ASD, and the fenestration was 6 millimeter, and it closed after 2 years. We had to put a stent in the fenestration to be following that.
Is it Mai from Egypt?
No, it's Amal from Egypt.
Okay. Amal, your voice
It was
is
published.
Okay, your voices were very similar. Now I will tell you, our practice on fenestrated devices are to give dual antiplatelets, aspirin plus Plavix together for make it zoom, make it mag, aspirin plus Plavix together till we don't want the fenestration to be patent. So until that
She
time we
was
give.
on aspirin initially, but when it closed and put the stent, we actually put her on warfarin, small dose as well as aspirin.
Okay.
So the stent is still open.
Yeah, I was telling that our pattern, the way in which we work is always give Plavix. We don't withdraw the Plavix as long as we desire the patency of this. So now we are able to see by thoracic echocardiogram the flow through this fenestration, which is going through and through, and now that's the device. We are able to see. I will also show now this fenestration by fluoroscopy. Come to RAO cardal. Get ready to release, Vishnu. No, just give me some space.
Before you release that, Siva, does anyone in the audience think this device is too big and too bulky?
Go
I just
further.
was asking if there was a range, whether you consider a smaller device
Little
based on
elevo.
the waist of your balloon.
Little elevo. Enough. Now, மூச்சு நல்லா இழுத்து பிடிங்க. நல்லா take a deep breath and hold. மூச்சு இழுங்க. Take a deep breath. Leave the breath. மூச்சு விட்டுருங்க. Now take a deep breath. Okay. What we are seeing, the fenestration is actually on the inferior side of the, you see the cable, and below the cable is the fenestration. Okay, the Salim's question about what sort of device, whether this is a little bit larger, we had a detailed transesophageal echocardiography yesterday, and the measurement was clearly 30 millimeters. Today the balloon was also 30.5 or 30.6 like that. I would like to be safer on the device because the last thing that I want in this patient is a device that gets embolized or a device that gets malpositioned. So I intentionally oversized by +4 in order to make the device pretty stable. This is a patient where there is a lot of hemodynamic disturbance and I don't want an additional, come to AP and release the device now, Vishnu. Yeah. So, Eric, your question of whether we could have used a little smaller device, yeah, maybe 32. However, like I was not tempted to like try a significantly undersized device. Now we can take out the PA catheter also. What is what you would have chosen, Eric? In fact, half of the people decided to choose a complete device, whereas we decided for a fenestration. And what you would have chosen? Probably a 32 or a 30?
I was looking at a 30 or 32 if you had them available.
Okay. Yeah, they were available, but the reason why I selected a 34 was that I wanted to go +4 from the transesophageal echocardiogram size. Transesophageal echo, I myself did it yesterday and it was clearly 30. So I didn't want to lose on it. Now, as I speak to you, I'm just moving to the next lab. The next lab is having a very interesting rheumatic heart disease.
I know that you have very interesting cases. One last question.
Yeah.
You will continue your pH therapy, and when do you repeat her actual PVR hemodynamics?
Our protocol is within about 12 to 18 months, she will come again into the cath lab. She will continue on dual pulmonary vasodilator. She will be on bosentan 62.5 milligram 2 times a day, sildenafil 20 milligram 2 times a day, aspirin plus Plavix, and then she will come back to my lab at the end of 12 to 18 months. A repeat cardiac hemodynamics will be done. If the PA pressures are in the moderate zone, she will continue on dual pulmonary vasodilator. If the pulmonary artery pressures are significantly low, almost to high normal levels, we will take away bosentan and continue her on sildenafil for another 3 to 4 years. We will repeat another hemodynamics at the end of 3 to 4 years. And if the PA pressures drop to complete normalcy, we will stop clopidogrel, we will stop sildenafil and continue her only on aspirin. This has been the protocol that we are following. I am moving now to the next lab, but I am still ready to take questions from you while I am requesting my colleagues to give the case presentation of the next case.
Okay.
Thank you.
Can I say something? Just a comment, actually. Siva did a great case. I think we see this a lot in our setup, people coming in late with pulmonary hypertension. I think one of the most important things here is to actually evaluate them pre-procedure. And one of the things which we routinely do, and I'm sure Shiva would have done, is to do a 6 minutes walk test. If they are fully saturated in air, and if you see any desaturation in a 6 minutes walk test, we would not take them to cath lab. We would put them on pulmonary vasodilators and then repeat the 6 minutes walk test 3 months down the line after we have given them pulmonary vasodilators.
If there is time,
you look at the chest X-ray, you look at the patient holistically. So I think it's important to understand that these patients are very different and they need to be looked at not only individually but in a logical way, and not to take everybody to cath lab unless you have to really. Thank you.
Thanks, Masood. I don't think we even talked about pregnancy counseling either. So we're in the next room. Congratulations on the last case. You didn't hear our applause, but trust us, it was there silently.
Okay. Is that the last words were from Masood Sadiq?
Oh, discussion of pre-procedure or even pre-cath 6-minute walk testing. If a patient is desaturated, would you even consider cathing them, or would you place them on pH therapy and then retest them 6-minute walk?